Hello and welcome to another edition of Medical Day. I'm Jared Rutnam, and on today's show we'll be taking a look at gastroenterology, problems with your gut. Stay with us because we're going to give you some information about that. We're also going to be talking about osteoporosis. That'll be coming up shortly right here on today's edition of Medical Day. But for now, we want to talk about HFMD, better known as hand, foot and mouth disease. Everyone's been talking about it to give us a better understanding or to walk us through the basics of what this is. I'm joined by Sharifah, Fauziyah, Syed, Mohthar, Director/Pharmacist for Regulatory Affairs, Pharmaniaga. She joins us once again. Thank you very much for joining us, Sharifah. It's a pleasure to have you here.
Yes, thank you, Gerard.
Well, it's been in the news. Everyone's been talking about it,
yes.
HFMD, and I guess it's only right that we talk about it. And basically, when we talk about it, to take away all the stuff that's too technical for people, give us a better understanding by just knowing the basics. Yeah.
Mm-hmm.
Yeah.
Yes,
So
agreed.
when we talk about HFMD, let's start with what is hand, foot, and mouth disease.
Okay, hand, foot and mouth disease, HFMD, is a viral infection, and it affects generally younger children, say under the age of 5, and it's generally demonstrated through these symptoms: fever, blisters in the mouth, which can also appear on the hands and the legs, the foot, as well as poor appetite, and acute. It can also happen acute diarrhea and vomiting.
Well, it's very interesting that off the air we were talking about this, and you did correct me. I was saying about how it is come about with so much news surrounding it, and how it's there's an exponential growth in the rise of it. And you said there's not an exponential growth, but people, it's just that we talk more about it now.
Yes,
how do you better explain this?
Basically, I think foot and mouth disease, the virus, for example, has already been there. It's always there. It's just that how it is being communicated, from one person to another. And yes, there is an increase this year. I think, if I'm not mistaken, the figure is about 20% increase from last year. And I guess because the basics of managing HFMD is basically through cleanliness, so I think we need to take a look at how we manage, cleanliness of the individual, of the environment, and the whole.
So for me to say that there's an exponential rise is not too correct. I said growth first, said that's bad. An exponential rise, that is not true. So all of us are talking about it, hence that's why we think there's a lot of cases happening right here in the peninsula, also in Sabah and Sarawak. Now, let's talk about what causes it, the causes of HFMD.
Okay, basically I mentioned earlier, it's a viral infection. There's a virus from the group enterovirus, but within this group of enterovirus, there are several different types of viruses. So, for example, there's Coxsackie virus, EV71. So these are examples of viruses that could cause HFMD. But there are also other viruses within the same category that doesn't cause HFMD. Generally, it's caused by EV71 and Coxsackie A16.
Now, once someone's exposed to it, how does one contract it? What kind of exposure leads to contraction?
Okay. It depends on individuals. It can be as early as 3 days and as long as 7 days. So within those 3 to 7 days, what we call as the incubation period, the person may not manifest anything, but after 3 to 7 days, then the first symptoms will start to appear, which is normally fever.
Okay, so they say, you have to be careful because you or your kid may pick it up in a shopping mall.
Yes.
Does that have any truth to this?
Yes, yes. Actually, yes, there is a lot of truth because the viral infection is contagious. And it is spread from one person to another, actually through direct contact. One direct contact either with the discharge, I think I've got this here, either discharge from the nasal discharge or the saliva, or fluid from the blister or the rash, okay, or direct contact with the stool. This is especially for caretakers, right? Or it can also be direct contact with the surfaces. So we're talking about, if you're talking about kids, if they touch the toys or maybe even door handles, so you can actually contract it, getting it by touching all of these infected or contaminated surfaces.
So people who work in the service industry and people who work in hospitals, their kids are they more prone to or susceptible to it?
Yes, they would be in a higher risk because their parents would probably be carriers, but it is very important, like I said earlier, cleanliness is very important. As long as certain level of cleanliness is maintained, I don't think they should be worried about it, basically.
Right.
Yeah.
Now, when we talk about cleanliness, let's go back a little and talk about seriousness. Okay. So then we'll come back to cleanliness.
Okay.
Now, how serious is this problem?
Well, generally for most people, HFMD is a mild infection. Okay, not a very small percentage actually get complications from the disease. And I think for this year, we've recorded about cumulative numbers from KKM is about more than 44,000 cases since January. But we've had 2 unfortunate deaths.
Right.
So, but these are those that actually develop complications. But otherwise, once you get it, within a week or maybe maximum 10 days, it'll go away.
So the ones that develop or people who are prone to complications, what kind of complications are we looking at?
The complications can be in a form of viral meningitis, and that could also lead to respiratory issues as well as cardiovascular issues. Yeah.
Now, treating the disease or the virus or the symptoms, how do you go about doing it?
You don't treat HFMD. Okay, there's no medication to treat it, nor are there any medication to prevent it. But what you do is, normally what clinicians do is they would treat the symptoms. So I mentioned fever, so you treat the fever. Normally clinicians will prescribe the simplest form, paracetamol or ibuprofen, and you treat the blisters because that can be very very painful for the child. So you can treat them, especially in the mouth area. And for example, like Pharmaniaga, we do have product called Aftermat, which can be used
for symptomatic relief.
Yes, for symptomatic relief. That's right. And for the skin rashes is the normal. Maybe the clinician can prescribe just like calamine lotion, something to soothe the kid down.
So for a company like Pharmaniaga, it's very important that you collect data. Say this year, now that it's being talked about from January till now, does Pharmaniaga go out on a survey to collect data?
Well, data is very easy to be accessible right now through portals like the KKM portals. Yeah, that's where we get our numbers. But aside from that, what Pharmaniaga does, I think more importantly, is to advocate proper cleaning methods, proper how you take care of your cleanliness and your environment. And we have been doing that actually in the last couple of weeks. We've been actively declaring a war against HFMD.
Right, because it's just going out there and giving people more information as to what hygiene and cleanliness
correct. We give people information, and we actually have a poster where any schools or kindies or schools or nurseries can actually contact us if they need any kind of assistance with hand sanitizers. And we've also gone out to assist in terms of cleaning some of these sites.
So there you go. Pharmaniaga is lending a helping hand in giving out information about cleanliness. Most of us talk about cleanliness. Do we know what it is? This is Pharmaniaga's war on HFMD, right?
Yeah.
So can you walk us through this?
Yes. So basically, we've put this poster up on social media, and any school operators, registered school operators or nursery operators can actually call us. Okay, this is the fax number.
Can I do my
Yes,
Patrick Theo radio voice for this?
Please.
03-3342-6629. It's 03-3342-6629. If you missed that, it's 03-3342-6629.
Yes.
Did I do well there?
Yes, you did very well. And so far we have received, I think, more than 500 requests. And we're in the process of approaching all these 500. And I think the numbers are coming in.
Right.
Yeah.
So coming back to cleanliness, most of us know washing your hands, okay? Washing your hands, washing your face, washing your feet when you come into your house. That's cleanliness for us. You know? So to move to get a deeper understanding of what cleanliness we're talking about with regards to the war on HFMD, what else do we need to do?
Okay, when you say wash the hands, it's not just simply making sure that your hands are wet, right? There is a technique to washing the hands. You need to at least do it for 20 seconds and make sure all the areas are covered with water and soap. And that is for personal hygiene. And aside from just washing the hands, we could use hand sanitizers, of course. Secondly is the environment. So the environment needs to also be clean. So we can also make sure that we sanitize the environment.
Right. The thing about hand sanitizers are, a lot of people think that, hand sanitizers, chemicals equals chemicals. I'm not going to use them. What
put it this way, you're not going to be using them
all the time.
Yes, right?
Correct.
So it is good to actually use for protection. But again, the proper hand washing is still number one.
Right.
That's still number one.
So proper hand washing, doing
yes,
this
yes,
and this.
yes. You know, make sure everything.
But if I do go to a hospital and I'm worried about contracting HFMD somewhere in the hospital, I need to use sanitizers there.
Yes, you need to use, correct.
Right.
Correct.
So there's no problems with that.
Yep.
But if you were to use it every day, then it may be harsh on the skin. So you also need to know that hand sanitizers play an important role in the war against HFMD.
Yes, correct.
Yeah.
But it doesn't rest there. Besides ensuring the cleanliness of the self and the environment, it's the third part is what you call as isolation. If you have a kid with HFMD, you need to keep him or her in isolation.
Right.
So that there is a minimum risk of...
So what about you? If you keep your kid in isolation, what risk do you pose to people?
Okay. For adults, the risk is actually lower because the risk is more towards children 5 years and below. Generally because number one, they have lower immunity. Okay. Secondly, they don't really take care of their own cleanliness. So to answer your question, a caretaker would have lesser risk in these two areas, higher immunity, and we take care of our cleanliness much better than the kids. So we shouldn't be not an issue.
Okay, so
for
saying
the children,
if
for the
I
adult.
have kids and my kid has HFMD and I go to my sister's place, my sister has kids, you know, do they stand a chance from contracting it from?
Don't bring your kid. Leave your kid
just
at home.
don't bring your kid.
Yes, leave your kid at home.
And cleanliness is of course important at all times. When you leave home, make sure you're clean. Any other advice for us before we close this segment with regards to the war on HFMD?
Yes, I think we've covered it all. The staying away from public places, and of course getting medical attention when the symptoms are there. Right? Don't just not do anything about it.
Stay away from public places. Get medical attention once symptoms are detected. Practice good hygiene. Disinfect your floor, your furniture, and toys. And dispose of diapers properly. How do you explain that?
Because the virus can be found in the stool of the baby. So you really need to make sure that whoever the caretaker that's handling the diapers needs to make sure that it is disposed of properly. So this would be more prevalent in places like nurseries, where you have so many other babies, and you have.
So if you're running daycares or nurseries,
exactly,
you need to take this very seriously.
Yes, correct.
And last but not least, like you said before, that one Pharmaniaga has a war, has called for a war on HFMD. They're going all out. If you need any help, send them an email at comms, that's COMMS at Pharmaniaga.com, or I'll give them a call or send them a fax at 03-3342-6629. This is Pharmaniaga's War on HFMD. On that note, we'd like to thank Sharifah Fauziyah for joining us right here on Medical Today. We'll be back just after the break. Fauziyah, thank you very much.
Thank you very much.
Stay with us. We'll come back shortly, right here on Medical Today, Bernama News Channel.
The Nation, a talk show from the Current Affairs desk with in-depth conversations on health, women, property, culture and performing arts. Only on the Bernama News Channel.
Listen to views of industry captains. Analyze and examine trends and projections. Gain market insights from subject matter experts. Biz Talk every Friday only on BNC.
Accurate, legitimate, and packed with information. First on site with reports from across the country and around the world. Be in the know through Bernama News Bulletins. Only on Bernama News Channel. Brings you the latest in current affairs, lifestyle and entertainment, as well as one-on-one discussions with fascinating personalities. Only on Bernama News Channel.
Hello and welcome back to Medical Today. We just had some information, or received to be exacting, some information on HFMD. From there, let's talk about the gut, something I like talking about, gastroenterology. We've got Dr. Chen Harn, a consultant gastroenterologist from Ramsay Sime Darby Healthcare, joining us right here on today's edition of Medical Today. Dr. Chen, thank you very much for taking time off your busy schedule to be with us. Well, today we're going to be talking about cancer, colon cancer. Yep. Why did you pick colon cancer as your topic? Are you going to give us bad news?
No, good news. So I think just a brief introduction to colon cancer. It's something that's very dear to me.
Right.
But firstly, thank you for inviting me here to speak on colon cancer. So colon cancer is one of the most common cancer in the world and in Malaysia. And basically when we talk about colon cancer, it means cancer of the large intestine. Mm-hmm. If you look at the National Registry for Cancer in Malaysia, colon cancer is the second most common cancer. Right. And in males, it is actually the most common cancer. and in females it's the number 2 after breast cancer. So
why is it very dear to you? I had to pick up on that.
yes, it's dear to me because
If it's personal, you don't have to bring it up. Yeah.
I mean that's personal as well, but it's one of the most preventable colon cancer. So I like to talk about it because if there is knowledge about colon cancer and people pick up on the screening and they actually go for it, then we can actually reduce the incidence of colon cancer.
Right.
And,
So let's talk about screening methods first.
Sure.
As a gastroenterologist, you'd probably want to run a couple of scopes back and front
Yep.
sometimes. Okay.
Yep.
And when you run these scopes, what happens after?
The scope procedure basically, I mean, we have a few scope techniques. One to look at the stomach, and for colon cancer is basically endoscopy to look into the colon. And how we do it, basically we have a long tube which has a high definition video camera at the end of it, and we introduce it throughout the whole large intestines, basically to look for lesions such as polyps. And these are the things that causes colon cancer.
Right.
Yeah.
So polyps, safe to say, would be the start of colon cancer?
It's the start before it becomes colon cancer.
All right. So when you ascertain that, when you found polyps,
Yeah.
What happens next? What other tests do you run?
So before we talk about what we do about the polyps, I'll just go into a bit of detail about
Right.
how it becomes
Sure.
colon cancer. So it's something that's pretty common. If you look at general population, by the age of 50, about 15 to 20% of people will start having polyps in the colon. So polyps are not cancer.
Right.
But when you have polyps, then as time goes, this polyps gets bigger. It will have some changes within the polyps, and it will turn to cancer in the long run. So the whole course takes probably about 10 years. And when we do colon examination, basically we are trying to find these polyps, we remove it, and thereby we actually prevent colon cancer.
Right. So when these polyps are found, you'll remove it straight away.
Yes.
While you're doing the scopes, it's
Correct.
done. So if what size must the polyp be for it to be removed? How big should it be?
Oh, we remove polyps at any size.
At any size.
Correct.
Yep. So, but I guess that there seems to be some red flags here. So if you're going for a scope,
Yep.
And if you're on blood thinning medication, you need to
Correct.
inform your doctor first.
Definitely.
Or the polyps can't be removed then.
Yes.
Yeah? Okay, then what happens next? Okay, you have the H. pylori test, which is also done to check for bacteria.
Yes.
What else is done in the gamut of tests to ascertain colon cancer and everything else?
Okay, so screening-wise, mainly we are looking at to find polyps in the colon and to try and remove it, and that basically prevents colon cancer.
Right.
But if you reach the point where the polyp has become a cancer, then that is different. So we don't remove those lesions, and those lesions needs to be staged, whereby we determine how advanced the cancer is, and then we proceed with doing all the special tests to stage it, followed by treatment. And the mainstay of treatment is surgery.
The mainstay of treatment
Correct.
is
Surgery.
always surgery.
Yes.
And with surgery, when you go for surgery, I guess people in the working world would want to know, after surgery, how soon can I be back on my feet and lead a normal life again?
Usually, with surgery for colon cancer, if it's an early colon cancer, then surgery by itself is sufficient, and usually recovery is pretty fast. In some colon cancers, they can actually do the surgery laparoscopically. I'm sure my surgical colleagues will give a better information on that, but recovery is pretty quick.
And recovery.
Yeah, so
is
weeks.
pretty quick.
Yeah,
Right. Let's go back to the signs and symptoms.
sure.
Now, with gastrointestinal problems and colon cancer,
Yeah.
I think the signs and symptoms, and a lot of us go to Dr. Google to try to get information as
Correct.
soon as we're belching too much or with too much gas
Yeah.
or we're bloated or distended. We're always going and Googling on our own, case in point, me. Right. But what are the signs and symptoms?
So
the actual red flags for us to go
Sure.
see a doctor?
So we have a few symptoms which we consider as red flags, which requires very prompt investigation.
Right.
But sadly, when you have these symptoms, most of the time, if it's a cancer, it's usually advanced. Yeah, so that's where screening comes in. So we try and pick it up before it becomes an advanced cancer. The red flag symptoms for colon cancer, we have a few. Firstly would be an altered bowel habit. So for example, if you are going to the toilet regularly once a day and suddenly you find that there's a change, you go to the toilet 2-3 times a day, you have runs of diarrhea, sometimes constipation, then that's what we consider as a change in your bowel habit.
Right.
And that
between diarrhea and constipation.
Yep.
Yep.
And also the stool consistency. And that happens in about 40% of patients when they present with colon cancer.
Yeah, but if you go see a GP, the GP may say that may be IBS.
Correct.
Let me put you on something for IBS. So what happens then?
So before we discount it as IBS, of course, there's a few factors you look into. One is the age. 2 is whether they have any family history, which I will probably go in a bit later.
Right.
But also the duration. So if your change in bowel habit is something that is persistent, it's not like just a couple of days, runs to weeks and all that, then if you're at a certain age, probably above 40, you should get it investigated.
So I guess the primary healthcare provider plays a very important role
Definitely.
in giving you the information you need,
Correct.
or directing people to you in
Correct.
order to get the help in time.
Yeah.
The earlier people come, is it better?
So as I was mentioning, by the time you have symptoms like change in bowel habit, blood in the stools, pain, weight loss, usually these are patients who already have advanced lesions.
Right.
So that's where screening comes in. So when we talk about screening, you want to try and do the investigation before you have any symptoms. So usually when you do that, you will pick it up before it becomes a cancer, or you will pick it up when it's a very early cancer,
Right.
and that is very treatable.
Right. Well, before we take a short break, let's dial down to the human side of things for
Sure.
a while and come back and talk about screening and all the other technicalities. Now, in your area of speciality, when you find that someone has developed cancer,
Yeah.
okay, or colon cancer, how do you, how do you talk to the person? How do you tell him, sir or ma'am, you have cancer?
Having cancer, colon cancer, is of course bad news. But the good thing about colon cancer is it's one of the most treatable cancers, and especially if it's early, the cure rate is very high with a low rate of recurrence. So usually I will reassure my patients that although it's bad news to have colon cancer, if you get it treated promptly and properly, then the outcome for them is still good.
Right.
Yeah.
We'll take a short break and we'll come back and talk about family history.
Yeah.
There's just a few other things we need to deal with in understanding colon cancer. So we'll take a short break. When we come back, Dr. Chen's going to walk us through family history and a few other things we need to know in order to have a better understanding of what colon cancer is. Now, I'd like to warn you once again that colon cancer, as he is ascertained, is the number 2
Most common cancer
in Malaysia. So deal with that for a while. Think about it. We're going to take a short break, and when we come back, Dr. Chen is going to walk us through the rest of the information we have for you on today's show with regards to colon cancer, right here on Medical Today, BNC. Stay with us.
Yes, I do. Because as a Malaysian, it's an act to show like how I love my country, and I will hang it at outside my balcony. So I show like, oh, the celebration is coming and the festival is around the corner.
Memang akan pasang tahun ni. Sebab pasang ni memang tahun-tahun sebelum ni pun kita pasang. Okay, tujuannya adalah untuk meningkatkan lagi semangat patriotisme dan bendera ni juga melambangkan kebanggaan negara kita.
Ya, saya akan mengibarkan jalur gemilang di kediaman saya untuk tahun ini. Sejujurnya untuk kali pertama saya mengibarkan adalah kerana untuk menunjukkan rasa cinta saya kepada negara kita Malaysia. Yang seperti kita tahu, Malaysia telah reborn, dilahirkan kembali. So lagi setelah semangatnya saya untuk mengibarkan bendera itulah.
Ya, semangat kemerdekaan selama negara kita merdeka ni, memang setiap tahun saya pasang bendera.
அரசியல், பொருளாதாரம், சமூகவியல், அறிவியல், விளையாட்டு, கலை, இலக்கியம், அனைத்துலக செய்தி என உடனுக்குடன் தகவல்களை கொண்டு வருகிறோம். புதிய பொலிவோடு, புதிய நம்பிக்கையோடு பர்னாமா தமிழ் செய்திகள். பர்னாமா அலைவரிசையில் மட்டுமே.
Hello Malaysia and welcome back to Medical Day. We're currently talking about one part of gastroenterology, which is colon cancer. Big thing in Malaysia, apparently the second biggest cancer in Malaysia, taking a lot of lives. If it's not checked, well, it can be checked, things can be changed. And we have Dr. Chen here from Ramsay Sime Darby Healthcare to tell us a little bit more about this. Let's move into, they say that history will teach you nothing. Now, after speaking to him, I think that's wrong because you need to know your family history with regards to this. So what do you need to know about your family history in order to understand colon cancer within your family tree?
So we are actually going to what the risk factors for increased risk of having colon cancer. And basically you can divide it to two big parts. One is something that you can control, which is lifestyle risk factor, and one that you can't control, which is your family history or genetics. Among the risk factors, I think family history is probably the most important. So if you, for example, if you have a first degree relative, father, mother, siblings who have colon cancer, if you have one of them having colon cancer, your risk of having that goes up by about almost two times. If you have two members who have that, the risk goes up to about 3 times.
Right.
So family members with colon cancer, then usually we advise the family to get screened early. So these are things that you can't control. You have certain genetic conditions as well. We have the Lynch syndrome, FAPs, which present with colon cancer at a very young age. So if we can identify the family members, then we screen the rest of them. Lifestyle risks. So there are certain lifestyle risks that can increase your risk for having colon cancer. Smoking is one of it, and heavy consumption of alcohol, obesity, diabetes. So these are things that you can try and modify to reduce your risk. Yeah, but in the end, the best way to actually screen for colon cancer is to prevent it by screening.
But you hear a lot of people, sorry I'm digressing,
Sure.
I like to digress.
No problem.
You hear a lot of people talking about the pH within your gut and how if that's not maintained, you run a risk, your risk becomes higher of developing colon cancer. I'm sure you've heard a lot of these cockamamie on the outside.
So these are, there's a lot of news you can get from internet portals and all that about what increases the risk of colon cancer and all that, but we base it on studies and science. So the ones that we know can increase the risk factors are what I mentioned. Of course, having a good lifestyle, being fit, exercising, all this actually helps to reduce the risk of that.
I remember one doctor telling me a long time ago, what you put into your mouth, be careful of what you put in and what comes out of your mouth. Well, speaking of which, some say, or there's some studies that talk about how certain cancers discriminate racially. Say, like in Malaysia, the Chinese are more susceptible to certain cancers, and the Indians to others. Of course, heart problems. Well, but can you tell us a little bit more about that?
Of course, there will be racial predisposition, I think partly because of genetics as well. If you look at colon cancer, the Chinese would probably have the higher risk as compared to Malaysian.
Has there been studies done on?
So we are basing it on the cancer registry. So on the cancer registry, you can actually see the amount of patients who have been diagnosed with colon cancer, their race, their age. So most of the time, as I mentioned, Chinese actually has the higher risk. And age-wise, most of the time they present by about 55. But there's an alarming trend where we are actually seeing younger patients getting colon cancer now without family history.
Do we have an inkling as to why that's happening?
It's probably the lifestyle as well as the food intake and probably pollution. So we're not very sure.
Right.
Yeah.
So we're hoping to get some answers with regards to that. Now, you've seen a patient. Okay, you've ascertained that he or she has developed colon cancer.
Correct.
Now, what's the follow-up on that?
Okay, so once you're diagnosed with colon cancer, of course, we need to stage it, as I mentioned. And staging basically determines what type of treatment they will get. So if you have an early colon cancer, surgery would be curative. If you have a more advanced colon cancer where it involves the nodes around the bowel, then you would probably need chemotherapy and sometimes radiotherapy as well. And if it's going towards other organs where it's metastasized, that's a stage 4 cancer. So at that point, there's no cure.
Right.
Yeah.
Let's backtrack and go back to polyps. Say if you've noticed polyps and you've removed it during the scope, is there a chance for it to come back?
Yes. So if you have polyps, the risk of having newer polyps coming in is there. So in terms of doing colonoscopy screening for colon cancer, when we do the next screening colonoscopy would depend on what we find from the previous scopes. So if you have a lot of polyps, then obviously your next colonoscopy examination would be earlier, which is probably about a year to 3 years. If there's no polyps at all, basically you are cleared for probably about 5 to 10 years.
5 to 10 years. So it's safe to say that if you're clear, every 5 to 10 years you need to do a gastro check.
Colonoscopy.
Colonoscopy, yeah. So what about those who have indigestion problems all the time? Just problems with acid and normal gastro problems. When do they have to go and check?
So again, gastric problems is actually quite common. So H. pylori infections, motility issues, all these can give rise to gastric issues. So if there's any alarm symptoms, of course, you should get it checked.
Now, as a gastroenterologist, with regards to colon cancer, we've kind of covered it. Now, what would be your sage advice or tips with regards to having sound gastrointestinal health?
Okay.
And colon health.
So, know your risk factors. Make sure that you get screened. So when we talk about screening, as I mentioned, you want to do it before you have the symptoms. So if you look at the national recommendation, worldwide recommendation, they actually recommend screening by the age of 50. In America, they are probably going to try and bring it down to 45. So go for the screening, and basically that would reduce your risk of having colon cancer by almost about 60 to 80%. Yeah, and colon cancer itself, even if you have it, it's one of the most one of the better cancers, and the survival is actually very good. So, for example, if you have stage 1 colon cancer, your 5-year survival is 90%. Yeah, stage 2 and 3, it goes up, is from about 60 to 80%. But if you're at stage 4 where it's metastasized, then it's pretty poor. It's about 10% in 5 years. But it's still better than a lot of other cancers.
Now, another area people tend to forget or lose sight on is the psychological effect these things have as soon as they're told something. You know, you tell someone that he or she has got something, the minute the person goes home, it starts to play in their head. How do you deal with that with regards to, I mean, when someone is in your care as a patient, how do you deal with that? How do you deal with them psychologically to keep them in check?
You need a lot of empathy with the patient. So it's a devastating news to be diagnosed with colon cancer. So I always try and get the family members around to give support when we break the news. And also we try and reassure them that with the treatment for colon cancer now, the survival is actually very good. So that would give some reassurance to them. And if you look at the trend, there's a lot of advancement in colon cancer treatment. There's immunotherapy, there is molecular-based therapy. So I always try and reassure my patients not to give up hope.
Right. There are many options out there with the development of different technologies. So options are available.
Correct.
With regards to help. What would be your final word of advice before we close this segment? Don't eat red meat.
Yeah. be healthy. Don't forget, it's like insurance. So screening is like insurance. So it's preventable. So if you go for it for the screening, there are other methods compared to just colonoscopy. We do stool tests as well,
right?
And CT scans. So just go for the screening. If you have any of the alarm symptoms, please seek medical attention as soon as possible.
Right. On that note, Dr. Chen, it was a pleasure and an honor having you here.
Thank you for having me here.
We just spoke to Dr. Chen Han Chin, a consultant gastroenterologist from Ramsay Sime Darby Healthcare. He came in to give us a bit of an insight with regards to colon cancer. Thank you very much, Doc. It was a pleasure having you here. You stay with us. We're going to take a short break. And when we come back, we're going to be talking about bone problems, osteoporosis, and more right here on the final segment of Medical Day. Stay with us. We'll be back with that shortly.
Syuk, betul lah kau tengok telefon ni. Kau tengok buat apa ni, Lily?
Ni Han, duk tengah tukar profil picture Facebook. Sekarang kan kita dah nak sambut bulan kebangsaan.
Betul lah. Aku pun sekarang nak tukar lah. Bo ada rasa macam semangat patriotik sikit. Sekejap.
Okey.
Ayo, aku dah tukar.
Yes.
Saya sudah. Anda bila lagi?
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 Anda sayangkan Malaysia? Tukarkan profil di media sosial anda kepada tema Sayangi Malaysiaku sempena Hari Kebangsaan.
Hai, saya Mazlan Evans.
Dan saya Fiona Adil.
Dalam rancangan Ha Gitu.
Ha Gitu?
Ha Gitu.
Sebuah program yang menceritakan
gosip-gosip artis, muzik, filem dan perkembangan dunia hiburan dalam dan luar negara.
Jangan lupa saksikan program
Ha Gitu? Ha Gitu.
Setiap hari Sabtu 9 malam di Bernama News Channel.
911 menampilkan pelbagai segmen menarik khas buat anda. Saksikan 911 setiap Isnin hingga Jumaat 9 pagi. Hanya di Bernama News Channel.
Program 1001 Destinasi Malaysiaku ke udara lagi untuk menemui penonton pada setiap Rabu pukul 10.30 malam. Saksikan paparan-paparannya yang membawa penonton ke tempat-tempat percutian yang menarik di dalam dan luar negara. Bersiaranlah bersama kami di Bernama News Channel BNC. Semuanya tentang anda.
Welcome back to the final segment of Medical Today. Before we get into what we want to talk about today, just send us an email if you do have any questions for us with regards to any medical problems at all. Send it to ask@medicaltoday.my. That's ask@medicaltoday.my. Send us an email and we'll also furnish you with a bottle of vitamins. I'll give you more information on that before we end the show. But for now, we have with us Dr. Lim Ping, a consultant orthopedic surgeon from Ramsay Sime Darby Healthcare. He's joining us on the show to talk about osteoporosis and bone health. Doctor, thank you very much for joining us.
Thank you.
Well, a lot of us are taking milk and taking all these newfangled products in the market in order to protect ourselves from osteoporosis. Everyone knows about this. When we get older, we're going to have brittle bones, so on and so forth. With that much information out there, why did you choose to talk about osteoporosis today?
I think osteoporosis is one of those that is a disease that has not been recognized well enough in our culture, in everywhere in the world, especially Asia.
Right.
The problem with osteoporosis is this. It's a silent killer. It doesn't show you signs that it is deteriorating. It is basically a reduction of bone density, a failure of bone architecture, therefore leading to fragility fracture.
But the understanding is, it'll only set in after my 60s and as I grow older.
That was the basic problem.
Yeah.
You see, if somebody tells you, look, you got to take your pills for hypertension because you're going to get a heart attack if you don't take care of it. And everybody does it. And from a young age, diligently. And you say, don't take too much cholesterol because it's bad for your health, because you get hypertension, you get stroke. Right. People understand right from a young age. Now, how many of us below 50 start preventing osteoporosis from happening?
Right.
How many of us exercise enough?
It feels like someone sent you in here to tell me this.
Yeah. Basically, all the young people are not doing their job.
Right.
They are not preventing themselves from getting osteoporosis in their old age. And I think me as a medical practitioner, we are not hardworking enough in doing our job to tell the public that, look, this is something we need to take care when we are young,
right,
and also to treat when we are old.
Yeah, this to me doesn't sound like an interview, it sounds like a story. So where do we begin with this story, Doctor?
Well, let's
Do you mind if I call you Doctor?
Yes, I think that's what we are here for. I think in the first place, all of us builds bone as a child, and as the bone is being built, we need elemental building blocks. Right, the building blocks are the calcium and the vitamin D3. Now, in Malaysia, in UST Malaya, they did a study on what is the amount of vitamin D in our blood. They find that a good 60% of 55-year-old ladies have inadequate vitamin D in their blood, in their serum.
So there's a depletion of some sort.
Correct, and that's because all of us every day do not go out in the sun.
Right.
We use umbrella to protect ourselves from sunlight. you and me sit in the aircon room.
Correct, but the thing is, if you get in the sun, they'll say you'll get skin cancer, so everyone's hiding from the sun.
No, but you only need 25 minutes of sun a day.
That's it. See,
onto
we
your
forgot
skin,
about this.
And your skin will convert that into good number of vitamin D for you.
Right.
You see? So in fact, that studies also prove one thing, that the urban ladies of 55-year-old and the rural ladies, they find that the rural one who works in the farm, who has more sunlight, has a higher level of serum vitamin D. That itself prevents you from getting osteoporosis and reduce the rate of fracture when you're older. You see? Now, calcium is another story. They did a diet evaluation of general Malaysian diet. How many of us do drink milk or cheese or a dairy product in a day? Especially the Chinese, most of them are lack of lactose enzyme in the body, and they say if I drink milk, I get diarrhea.
Right.
Now, with that, they actually look at our Malaysian diet. Generally, we have about 400 milligram of calcium per day in our diet. But the requirement, the RDA, the recommended daily allowances, is actually 1,000 milligram a day.
That's supposed to be, that's supposed to get into our systems via food?
By food or any which way you can. So of course, being natural is the best. But if your food gives you only 400, you have to supplement to 1,000 for that day. So in Malaysia, you either drink more dairy product, take in more green vegetable. Basically, our diet is inadequate. You get the nasi lemak, you get rice, but you don't get a lot of vegetables. You don't get a lot of anchovies, where a thing are there.
Right.
So somehow, and there's not enough milk in there. So in Malaysian diet, because it's inadequate, we should think of other supplementation.
Okay. So now, going back to what you first said, after we're 40, most of us don't worry about what's going to come with regards to bone health. So we need to start thinking about this.
Yes,
right?
so in other words, you must think of those below 40, we have to make sure their exercise is good enough. See, bone are like muscle. If you exercise the muscle will build up, you become Arnold Schwarzenegger.
Right.
Bone is the same thing. You use them, you exercise more, your bone will say, hey, I need a stronger bone to take that weight, and your bone will build. And therefore, that building part has to be below 40.
Right.
But how many of us are actually exercising enough, taking enough calcium, taking enough vitamin D?
See, there's a question here which is very interesting. Do Malaysian women need calcium and vitamin D supplements to prevent osteoporosis? Why aren't we targeting men?
That's because at menopause, okay, the hormone level drops, and therefore you find that the incidence of osteoporosis goes up exponentially after that. So during menopause, that is the time when the hormone has reduced, the female hormone, estrogen and progesterone. Your body is unable to bring the calcium and vitamin D into the bone and build it.
So it can't transport
You can't transport it in that layman term. So therefore, if you have passed menopause, and if you are sedentary, if your body weight is low, you stand a very high risk of osteoporosis, and therefore a high risk of a fracture.
Okay, are there tests we can do? Let's talk about diagnosis and diagnosing the bone health problems.
I think we are very lucky that in our country, in Malaysia, we have one of the best healthcare system in terms of diagnosing and screening. Now, we have 3 levels of screening. The first level is if you go to, say, a pharmacy, sometimes they run a screening where you put your finger in there or you put your foot in there. It's called an ultrasound-based screening. Now, they are not accurate, but at least they can tell you this is potentially an osteoporotic patient. If that is positive, okay, there's one criteria.
It can point you in the right direction.
Point you, then you go for the gold standard of screening, diagnosing osteoporosis, which is the DEXA machine, DEXA, which is called the bone mineral density. We call it BMD machine.
Right.
Now that one is available in most of the hospital. It only costs you about 100 ringgit, roughly about plus and minus 100 ringgit. Now, if the original ultrasound screening proof positive, then you should go for the DEXA machine. Now, the DEXA is recommended for either you have proof positive from the screening or you are 2 years past menopause. Because then the WHO says you are catching the highest group of population who are at risk of osteoporosis.
Right.
Yeah. Male do get osteoporosis, but because their hormone decline over a slower and longer period, so your osteoporosis set in another 10 years later. So at 65 and above, the WHO also recommend either your first DEXA scan or a simple ultrasound
At 65.
At 65.
That's not too much to ask for, isn't it?
Yes, that's
Right.
Yeah.
So
you
saying
should-
you've done a DEXA scan and you've ascertained that you have osteoporosis.
All right.
Now, what do we do medically in order to help treat the symptoms or treat the problem itself?
Yeah.
How do we treat it?
Well, if you already know you got osteoporosis, and that is before we had complication of an osteoporosis, therefore complication means a fracture leading to the need of surgery or treatment. Now that you know your osteoporosis, number one, you should go to a doctor, go to your family physician. You don't need to come to an orthopedic surgeon like me. All family physician knows how to treat osteoporosis. It's the basic primary health care. So what they do, they will look at your lifestyle, look at your whether you're postmenopausal or not, and look at what you call the T-score in the bone mineral density.
Right.
If the T-score is below minus 2.5 from the report, they will know that you established osteoporosis, and they will ask you your history, whether you have got a sister, an auntie, or a mother who has got significant osteoporotic fracture, or your mother who's 30 years older has got kyphosis. You know you're going on that direction because they are very genetically linked. They will then prescribe. Obviously, you need the building blocks, the calcium, the vitamin D, and they will give you a host of other medication to choose from.
Right.
Now, the choice is by the doctor. I suppose patients, laymen, should not take medicine on their own. We have got teriparatide, which is an injectable which builds bone by building the architecture of bone and bringing the calcium and vitamin D into the bone.
Right.
We also has got other drugs like alendronate, which are in the bisphosphonate group. We have got ibandronate, and these are all the drugs. And interestingly, this tablet can be taken once a week or once a month.
Right.
And there's also another drug called denosumab, which an injectable once in every 6 months. And once you take this for people who establish osteoporosis, then with your daily calcium and vitamin D supplement, that will build your bone. Therefore, you will have increasing bone mineral density every year. And you're making your bones younger.
Right, right.
Less fracture, less complication.
Lot of clarity on what you're talking about. So I guess the thing here is for us to ensure we take care of our bone health. We worry about everything else, hypertension, cholesterol levels. We worry about most everything except our bone health.
Yeah, the general population forgot about us, the orthopedic, the bone health.
How can you guys do that, man?
I know.
Yeah.
I think my fellow orthopedic surgeons didn't do a good job in the past.
Right.
And our job now is to educate the public.
To go out then.
To go out there and prevent it if you're young, and if you're old, you do a screening. If you have, there are treatment today. 30 years ago, there were no treatment. But today there are. It prevents you from getting kyphosis.
Right.
Being bent and old is not a choice anymore.
Right. You don't want to look gaunt when you're old. You want to be standing straight.
You should be standing straight. You should be able to sit straight even at 90 years old.
Right. On that note, we'd like to thank Dato'Dr. Lim Boon Peng, consultant orthopedic surgeon from Ramsay Sime Darby Healthcare. I'm definitely going to bring you in for part 2 on this. We need to talk more about bone health. On that note, if you do have problems with regards to osteoporosis, gastroenterology, you name it, if you have a question for us, send it to us. Send it to ask@medicaltoday.my. That's ask@medicaltoday.my, and we'll forward it to all the professionals coming in here and sharing information with you, hopefully to get an answer for you. When you do that, we're going to send you or furnish you with a bottle of vitamins right here on Medical Today. On that note, I'm running out of time. I have to sign off. Dato', it was a pleasure having you on the show. As always, it is a pleasure to have you with us on a Saturday. Thank you very much for joining us on today's edition of Medical Today. I'm Jared Ratnam signing off. You have a great weekend and a fantastic week ahead.